Hello, welcome to Week 2A7, Situational Vulnerability, Considerations and Safeguards when Exploring Gender Identity, Social Economic Challenges, and At-Risk Behavior. My name is Shayna Sambolian, Senior Membership Coordinator. Before we get started, I have a few announcements. The agenda and all conference content can be found on our online platform. The link is on this slide, and I will also put it in the chat. The platform includes links to all live sessions, on-demand presentations, slides, our virtual poster gallery and exhibit hall, and after the meeting, the session recordings. Resources are included at the speaker's discretion. As a reminder, you need to be logged in to access the site and all content. Login information was sent to you in advance of the meeting. If you experience technical difficulties during this session, review the help desk page on the meeting site or use the chat box. And please make sure to review the technical requirements section of the attendee homepage on the platform to ensure your system is set up properly. This session is being held as a Zoom meeting, so speakers and attendees can interact with one another using video and audio. Attendees are encouraged to use video to participate if they're able. During the session, please ensure you stay muted when not sharing. The chat box can be used to chat with colleagues, share knowledge, and make comments. You can also use the chat box to ask questions. Finally, we'd like to thank our conference supporters and exhibitors for their support of this meeting. Please be sure to visit their booth pages in the virtual exhibit hall during this event. Virtual booth pages include information and resources provided by the vendors. And some vendors are offering giveaways and participating in real-time video chat. We especially want to thank our event supporters, Advara, iMedris, and WCG-IRB, Tech Software, Cayuse and Prime IRB, and City Program and IRB-Net. I will now turn the session over to our speakers. Information on this session's speakers can be found on the agenda.
Hi, everyone. My name is Jonathan Hill-Rorie. I am speaking to you all from Boston, Massachusetts. I'm the project director of the Adolescent Trials Network at Fenway Health and the Fenway Institute specifically. Today, as Shayna said, we're going to be talking to you all today about situational vulnerability, considerations and safeguards when exploring gender identity, social economic challenges, and at-risk behavior. Next slide, please. This is just the conference content copyright. Next slide. None of the speakers today will have any relevant or personal, professional, or financial relationships with respect to the educational activity that we're doing today. So with us today also is Laura Bitterman from Portland VA Medical Center in Portland, Oregon. As I said, my name is Jonathan. I'm in Boston, and we also have Katie Speanburg with Apt Associates speaking with us from Saratoga, New York. They will give more detailed introductions of themselves when they begin speaking. Next slide, please. These are our learning objectives for today. What we hope to accomplish during this presentation is work through a definition of what vulnerability is in research, to define situational vulnerability, and to begin to think about how that affects research production and its dissemination. And then also talk through some strategies that we as IRB officials and researchers can use to mitigate risks for vulnerable populations. Next slide, please. And so now I'm going to hand it over to my colleague Laura to help to tell you all about situational vulnerability.
Jonathan. Hi all, my name is Laura Bitterman. I'm a nurse practitioner at the Portland VA Medical Center in Oregon. My main role here is as a primary care provider in the women's clinic. So I work primarily with women and gender variant veterans. So I wanted to begin by identifying a few papers and a few thinkers that helped me formulate my idea on this topic. Most of what I'll cover today stems from these ideas and conceptualizations. Vulnerability is this key concept in bioethics, and yet the phenomenon of vulnerability is often oversimplified and somewhat elusive. I think we take for granted the concept of vulnerability. Its meaning is self-evident. Intuitively, we know children or older adults with dementia are vulnerable, but when we explore it further, start deeming certain groups as vulnerable, the reasons for their vulnerability can become convoluted. And with this lack of clarity, it becomes hard to determine what then, if anything, should be done to safeguard these groups in research. So in an effort to understand the asks of an evolved, nuanced definition of vulnerability, I think it's helpful to start with the baseline as it was understood. When we look at the Nuremberg Code, there was this implicit assumption that all research participants are vulnerable. This gave rise to informed consent. As we know, several other documents further expanded upon the principles outlined in the Nuremberg Code, including the Declaration of Helsinki, the Belmont Report, the Common Rule. The Belmont Report is one of the first places we start to see populations delineated and specified. That is, if you are part of group X, then you are inherently vulnerable. And as it is in the Common Rule, vulnerability is mentioned 3 times, and the scope is now limited to vulnerability to coercion and undue influence. So it's made uniform across these three times, and it's, you know, children, prisoners, individuals with impaired decision-making capacity, economically or educationally disadvantaged persons. And when we look at these most recent conceptualizations of vulnerability in research ethics, it often results in this picking out of human subpopulations as vulnerable, that is, labeling. So the main critiques of this labeling approach is that it's both too narrow and too broad. It's both under and over inclusive. So when we start to deem whole groups as vulnerable, as with children, pregnant people, we undermine respect for personal autonomy. This can lead to unjust paternalistic protectionist policies. When we rely heavily on capacity for consent, or we rely solely on capacity for consent, this can miss circumstances like exploitation. You know, a better understanding of the research protocol doesn't mitigate risks to vulnerability like power dynamics or extreme poverty. Labeling misses the impacts of context and lived experience of a research participant. It can minimize the impact of a subject's ecosystem. If we label vulnerability, let's say, based on income, you run the risk of equating a university student who perhaps is temporarily has a low income, but you compare them with a chronically unemployed person who has a low income, perhaps without the expectation of getting out of that situation. Their needs and vulnerabilities are dramatically different and need different approaches. So then what, right? We have this list of vulnerable populations. We have decided that these groups need special attention, but it's not clear what that special attention should be. Luna introduces this layering approach to vulnerability, highlighting the concept as being relational, dynamic, as opposed to this fixed label. It depends on the context, situation, noting that layers of vulnerability can come and go. Lang, Rogers, and Dodds then build upon this to delineate these 3 categories of vulnerability: inherent, situational, and pathogenic. When you're looking at this, it's important to remember this is not a doctrine, this is not regulatory, but rather it's a useful framework, it's a useful tool for when you're working with vulnerable populations consistently. It's important to note when you're looking at this taxonomy, there is overlap. Much like the complexities of being human, there's no clean line between each of these. They interact, and I'll give some examples of that at the end. So inherent vulnerability refers to vulnerability that is intrinsic to being human, the vulnerabilities that arise from our humanness, our neediness, our reliance on others. So for example, we're biological social beings. We're all vulnerable to ill health, maybe a natural or man-made disaster. When I think of my veteran population, baked into the culture of military is this distinct hierarchy. And so sometimes a deference to hierarchy can be inherent, and that colors some of our shared decision-making conversations. Research shows that transgender folks inherently have a higher baseline stress. And so with my transgender patients, I try to keep this in mind. Situational vulnerability, this is context specific. It can be intermittent, it's short-term, enduring. So it's important, it doesn't imply an impairment in the ability to make choices. For example, these would be vulnerabilities associated with aid workers in a hurricane-prone area, but are rotated out, let's say, on a monthly basis to a more secure area versus the villagers that permanently live there. Pathogenic vulnerability, these are the vulnerabilities that arise from morally dysfunctional or abusive interpersonal social relationships, sociopolitical oppression, injustice. A key feature of this is the type of vulnerability that undermines autonomy. It exacerbates that sense of powerlessness. The way that I think of pathogenic vulnerability is that this is a type that's particularly ethically concerning. An example would be older adults who are inherently vulnerable due to their care needs, but are susceptible to pathogenic forms of vulnerability, such as financial abuse by caregivers. Another example would be an alarming number of the female veterans that I work with have a history of military sexual trauma. The distribution of power in the military, that chain of command, can increase the risk of this pathogenic vulnerability. And as I mentioned, each of these vulnerabilities are not categorically distinct. For example, health status, which is inherent, very much depends on socioeconomic factors, situational and pathogenic. Military sexual trauma is another one. It's both situational and pathogenic. Situational to service member veteran status, but it's pathogenic because of that abuse, dysfunction, inequality, and power. The distinction between each of these is useful, though, when we're looking at appropriate mitigation strategies. So it can help us separate those unavoidable human vulnerabilities from that are the product of fixable social injustices or inequalities, for example. We'll walk through some examples of how to implement that in a few moments. So thinking about vulnerability with this dynamic lens, the role of IRB or research coordinator should be design and implement research that mitigates inherent vulnerability and works to eliminate or minimize pathogenic vulnerabilities. That is, avoid making actual vulnerabilities worse and not making potential risks real by taking into account these individual, community, situational vulnerabilities. So when it comes to research ethics, I find it helpful to think of pathogenic vulnerabilities in two categories: the creation of and the exacerbation of. And what I mean by creation of is those pathogenic vulnerabilities that arise from research or policy interventions that were initially aimed at protecting, but in effect, they create new vulnerabilities. A really good example of this is the policies that exclude pregnant people from research, resulting in a lack of evidence-based information for that group. And as evidence-based medicine is the expectation, pregnant people now have limited treatment options as a result. Another example of the creation of would be if there's a study on cervical cancer screening in my veteran population, a pelvic exam is indicated. Perhaps an IRB would initially review and say that there's inherent risks of, say, cramping or pain, but the situational vulnerability that a veteran with a cervix may have is their increased risk of military sexual trauma. So by failing to address that situational vulnerability, the trial intervention protocol can create a pathogenic harm. And then an example of exacerbating a pathogenic vulnerability would be in my practice when I bill and code visits for trans veterans, many of whom transitioned years ago on gender-affirming hormone therapy for many years. I still have to code pathologizing terms like dysphoria, disorder. So when you're doing research on trans folks, the only way to conjure a proper chart review can be searching these ICD-10 codes that are stigmatizing, offensive, inaccurate, and implying that somebody is mentally ill. And I gave some more specific examples, but in your own practice, the general framework would be asking these 6 required questions, but with a situational vulnerability inclusive lens. And it should impact your study design and protocols. So feel free to read through these 6 questions. And with that, I'll hand it back to my colleague, Jonathan. He'll walk us through more specifically what it looks like to incorporate this information in practice.
Thanks, Laura. It gives folks a little bit of time to look at this, but I also wanted to let folks who just entered the room, and I kind of jumped the gun at the beginning, to give a little context that this, we want this to be a collaborative learning space. We don't want folks to ask any questions during the presentation, and there's space towards the end of the presentation where we want you all to be able to contribute your ideas, to use your expertise, because we know we have a bunch of different research professionals and IRB professionals that have a lot to share as well. So be thinking of what you want to contribute to the conversation as well. Next slide, please. So one of the things that we want you all to think about is like, how are risks to subjects minimized? So thinking of the board demographics, specifically considering like the racial, gender, and sexual diversity of the board, how many queer and trans people are represented on that board, how many Black and Indigenous folks are represented on that board. So are the studies that are moving through any of your individual IRBs heavily focused on recruiting from these historically or even currently oppressed groups? Like, even if that's not the case, like, this is still an important consideration for folks to make, because that will ensure that when those protocols do come up, or any protocols come up, that the folks who are reviewing that material have an intimate understanding of the issues that might arise over the course of the study, not just like general or tangential ones. When building up those boards, it's just important to remember that the lived experience that comes with having some of these identities is important when assessing and reviewing those different issues that might come up during the research. One of the things that I'm thinking about is, as a person who does youth studies in the Adolescent Trials Network, thinking about like what a reasonable compensation scheme might look like for the research. So thinking about how a 20-year-old versus a 45-year-old might think about payment for the things that they're doing and participating in. We also want to look at like community stakeholders. Similar to building like an inclusive board, it's important that there's community input and buy-in, whether that means actual seats on that IRB board that are filled by community members, or taking consultations via like a community advisory board, for instance, or some other means. It's important to make sure that that is incorporated into the review that's going on for those different studies. Lack of community oversight and input might cause some researchers and IRB officials to, like Laura said earlier, exacerbate or create new issues within the study population that they're researching. One of the things that I'm thinking about is payment methods for research. So again, back like to the payment schemes, are the ways in which you're paying and compensating your participants, what is most like accessible to them? Are you using gift cards, or are you doing like direct cash transfers to your participants? Is that something that they can readily access and have with them because they need like fungible money in that moment? So thinking about those and thinking through those things. Also, whether or not some of the implementation plans in the research might introduce more risk. For instance, a study that requires specimen collections in a population where that might be a triggering topic or like a dangerous thing. For example, folks who have like a history of substance use or may have had violent or harmful encounters with medical professionals who might have overstepped some physical bounds when collecting those specimens. So like keeping those things in mind when reviewing some of the materials. Then also just like general risks that are associated with sexual and gender minorities. So as Laura alluded to, like the history of mistreatment from medical and research institutions that have resulted in more systemic homophobia and transphobia that are kind of just like baked into a lot of the things that folks have to like navigate when they're participating in research in the medical field. A low level of like cultural competency of these IRB boards, and just like a general knowledge of LGBT issues on research teams and IRBs. And then one of the other things that's really important to consider with sexual and gender minorities is like participant outness. And so is the research potentially going to put a participant in a precarious situation where they have to out themselves to a family member, out themselves to their work employees, like having all that be considered when going over these different protocols. And then thinking about inclusive language throughout the process. So are the folks who your participants are encountering when they come in through the door of whatever research facility that you work at, are they trained on how to address clients by like asking pronouns, making sure that they aren't potentially putting folks at risk or triggering them when they walk through the door? That goes from as that person walks through the door to all the materials that they have to interact with when they're participating in a study, what other interventions, all the data collection tools, just thinking through what are the words that are being used and like what are participants asked to do and experience through that research process. Next slide, please. So we also want to see, are the risks reasonable relative to the benefits that are coming with participating in the research? So relevant to like the last statement I made, reviewing the data collection instruments. So I talked about like how language inclusivity through the research process is important. This also extends to like the data collection instruments that you're reviewing and are producing. So like, what does the language and the forms and the documentation look like? Is it binary? Is it forcing certain participants to choose something that they otherwise wouldn't? So like, are you asking a participant, are they a man or a woman, but they might not identify as either of those things? So what is that doing to your data robustness? What is that doing for like participant comfortability actually participating? And then making sure that like the skip logics of surveys that you might be producing are sending folks down the right path of the questions that they're supposed to get based on information they've provided to you. And then also making sure that participants are given an advanced warning of the things that might be asked of them. So not just giving them informed consent on like, these are the different things that I, as this researcher, might be requiring of you to participate in this study, but also there might be some sensitive topics that come up around gender identity, around your sexual orientation and sexual experiences that might be triggering for you. So like keeping that at the forefront as well, so that folks aren't just blindly participating in research that may end up re-traumatizing them. And then, as Laura mentioned earlier, sometimes risk might be exacerbated for certain subjects. And I'm thinking here about intersectionality. So it's often glossed over as some people just having multiple identities, when in fact it's really a theoretical framework for understanding how aspects of a person's social and political identities combine to create different modes of discrimination and privilege for folks. So in the context of research specifically, how might a status as a person being both queer, Black, and a young person all create a particular type of risk that might not be associated with someone who doesn't hold those different identities. And so when moving through the IRB and reviewing these different protocols, thinking about how folks are coming into the research and navigating it with a different set of risks based on who they are. And then thinking about ways to mitigate and control for like health disparities that might exist on those particular communities. Thinking about who is the population that you intend to study, what are some of the health concerns that are unique to them, what are the forces, thinking back to intersectionality and like the systemic forces that are at play that might be creating those disparities, and then considering those dynamics when reviewing the protocols. Are the studies that you're reviewing creating new ways of thinking about these disparities, or are they kind of like recreating the wheel and not adding new information, or even sometimes creating more harmful information that continues to pathologize these different communities? Next slide, please. And so is the selection of the subjects equitable? Thinking about like the requirements of participation in some of the studies, how might some of the requirements that you have set up for your studies might unnecessarily block some people from participating? Are the inclusion and exclusion criteria like absolutely necessary? Is there any type of wiggle room based on situation dependent cases? And are those like exclusion and inclusion criteria scientifically and medically relevant to what the study is that you're conducting? So like thinking about folks who are unable to get pregnant participating in a pregnancy study, that would make sense for them not to be included in that study, but something along the lines of, do you have access to a cellular data plan? Is there really a reason for that to be an exclusion criteria for this particular study? Who are the people that you might be leaving out when you make these types of inclusions and exclusion criteria? Thinking also about your recruitment strategies, what are the tactics that you're using, and are you reaching the people you intend to reach? So obviously when you're like producing ads and when you're producing certain types of content to recruit folks, it should be representative of the population that you're trying to recruit. But also you should be thinking about who are the folks who are actually producing that content, who are the people who are distributing that content to different folks, so that it reaches the population and can pick up on certain potential like cultural undertones that might not be understood outside of like that particular community. So when we were able to do in-person things in the before times, when going to in-person recruiting venues, are the folks that you're sending to those venues, are they potentially encroaching on intimate community spaces? Like, is that person's presence a disruptive force in that area? Say, for instance, sending someone to a gay nightclub that they themselves feel uncomfortable attending, so they just create a space of awkwardness for everyone involved. So thinking about those things when you're building up the recruitment plan and building up the review process of these different studies. And also thinking about how are you hoping to like gain participants? How are you hoping to like recruit these participants into the study? Is it a more passive approach by using these types of flyers and like social media advertisements where you're relying on people to see those ads and then matriculate into your study? Or is it a more active process by which you're like talking to people directly, reaching out to them via whatever means you have available to you and actually engaging in conversation with them? When thinking about those passive modes of like recruitment, are the folks who you need to be in the study actually going to be able to access those types of ads? So do they have access to social media? Do they have access to the places in which you're hanging these flyers? And even if they do have access, are they likely and willing to engage in those types of advertisements? During the political cycle, folks were inundated with a bunch of different social media ads, and just folks in general reaching out to them. So you might get people who don't want to engage with any type of like non-personal contact. So thinking then about like what is the best way and the safest way to like recruit these different folks. And then last on this slide, just ensuring a representative sample. Obviously you want your results to be generalizable to like the broader population, but then thinking about what is it that you're studying? Is there a particular population that is disproportionately impacted by whatever outcome that you're interested in, or that is disproportionately exposed to whatever thing that might be causing a particular health outcome? And are they the ones who are being sampled? It might be more pertinent to like do a purposive sampling method where you are actually targeting this particular group because you know that this group is the one who is most affected by this particular outcome or exposure. And so wanting that to be, having that be a part of your review process and helping the researchers think through whether or not like they're actually getting the people who need to be in this study based on like what they've presented to you as an IRB. Next slide, please. So we also want to make sure that the informed consent process in and of itself is accessible. So we want the language to be accessible, as we said earlier. We want to make sure that we aren't using language that might be harmful to the participants because you're misgendering them or providing binary language that doesn't allow for them to like see themselves as a person who could participate in this study. But also thinking about like the literal literacy level and like the accessibility of the things that you're trying to convey to them. So we all know that they need to be able to engage in the consent form so that they understand what's happening. But if you have a pretty complex study, what are the different ways in which you're trying to facilitate that understanding? Obviously using as plain as language as possible, but what are some additional facilitators that you can use, such as like visuals or any other type of thing that could help participants grasp an understanding of what it is that you're trying to get them to do, and making sure that as you're going through that process with them, that they are continually engaged. We also want to think about like situation-specific issues, such as like substance users or students who've returned home when at one point they felt safe, comfortable, and able to participate in your research study, but given a global pandemic now have returned home with their parents where they may not feel that same level of security and safety and privacy. So thinking about how you would navigate those type of situations and having that baked into the review process. And then we want to think about like the setting, the population, and the staff that's going into the consent process. And as you're reviewing these consent forms and reviewing these documents, like what are the things that, where are these people being consented? Are you consenting them in their own home? Are you consenting them in a virtual format? Are you consenting them at a research facility that may or may not make them feel more or less comfortable? Who is the person that is doing that consenting? Does it make more sense for them to be in like plain clothes attire to like dispel any sense of authority issues that Laura was bringing up earlier? Does it make more sense for them to be in like more professional attire because that will provide some sense of comfort? Just having an intimate understanding about who the population is that you are researching can help alleviate some of these different issues and like help minimize some of the risk that is involved in trying to recruit these subjects and trying to consent them into your research studies. Next slide, please. We also want to think about how you're ensuring the participants' privacy. So what are the identifiers that you're collecting to participate in that study? How much info is actually necessary to collect, and how much of that is necessary to participate and to get the research done in a safe way? One thing that I'm thinking about specifically is emergency contact information when collecting like locator forms for different participants. Is it required that do you actually need a person to reach out to if you can't get in touch with that person? Some queer youth don't have as extensive of a network or strong relationships with family who typically would be seen as emergency contacts in order to put that down. That also potentially puts them at risk of outing themselves to parents or outing themselves to partners, well, not partners, outing themselves to anyone else in their life who they might not be disclosing that information to. How are you collecting that information? And if they do have an emergency contact, what information does that contact have versus what this participant is disclosing to you? So are they using the same name with their emergency contact? Are they using the same pronouns with that emergency contact? Does this emergency contact know anything about the different things that may have come up over the course of this study? For data security, we're thinking about probably how are you storing that data? Who has access to that information? Is like all the bells and whistles that you can muster to like make sure that's kept private, but also thinking about how is that then being explained to participants, and how much nuance are you going into when you're explaining those different. So how much detail is too much, and how much detail is too vague to make sure the participants have a fine-tuned understanding of what they are getting in. That like the language of it. Is it too jargon heavy? Is it too, again, is it just too vague? And then also make sure that any state-specific requirements or specific issues, such as like privacy laws that like can vary from state to state, are explained to participants so that they know that what they are getting in here, say they have moved between different based on like where they are. So just having them engage with and ask as many questions as possible. Next slide. So now we're just going to move over into the case studies. My colleague Katie Speanburg is going to take over. And like I said, there's going to be time for folks to engage in the conversation. as she guides you through these steps.
All right. Thank you, Jonathan. Can everyone hear me? Anyone hear me?
Yes.
Okay, perfect. Jonathan, you were cutting in and out for me, so I'm not sure what happened to the sound. So thank you, Jonathan. Thank you, Laura. My name is Katie Speanburg. I'm the IRB administrator at Apt Associates. In case you're not familiar with us, we are a mission-driven research and consulting firm. We have about 4,000 staff worldwide, and I'm delighted to be here with you today. So as Jonathan said, I'm going to take us through 2 case studies. The first one about queer youth, the second one about trans veterans. And after each case study, I will ask the 3 same questions. I'll provide the answers that Jonathan, Laura, and I came up with, and then open the floor to you all to chime in with answers to the questions that you've thought of based on everything we've talked about today, and then of course your own experiences. So as a preview, the questions are: what are the situational vulnerabilities associated with this case study? How can the study be successfully conducted while mitigating these vulnerabilities? And how might the IRB view the study and the mitigation steps that are proposed? So I have a timer. I'm going to now give everyone 2 minutes to read the first case study. Okay, so next slide, please. All right, so when reading the case study, one of the questions that we're now going to discuss are: what are the different vulnerabilities that are associated with this case study? So tying back to something that Jonathan mentioned earlier, queer youth do have inherent vulnerabilities, especially if they are not out to their family and friends. So making it that interacting with this organization to participate in the study could actually become dangerous for those youth. In general, youth are more vulnerable, which is why we have special protections for them. So because we're trying to recruit youth, those under 18, into the study, those people may not have a full understanding of what it means to participate in a research study. They may not have participated in one before. They may feel pressure to participate based on influences of friends or social media. So just have to keep in mind the vulnerabilities that they have just by being a youth. If in the future or currently you're trying to conduct any in-person study activities, you should keep in mind that traveling to the clinic or the research site or wherever they're being recruited could be an issue. So, for example, the site may or may not be on public transportation. Access to parking could be cost prohibitive. I know, especially in Boston, it costs $40 just to drive into a parking garage. And then also, depending on whether youth are out to their parents or not, their involvement in the study and their children's lives may put the youth at risk of exposing something that they're not ready to discuss yet with their family. Some terms of situational vulnerabilities. As Jonathan said, during the pandemic, students may have returned home, or youth in general may have returned home to live with their parents or their friends or their family members. So receiving a at-home STI or HIV test kit may put them at risk of people that they are now living with finding out about them, finding out different things that they don't want to yet. And then in terms of mental health, I think it's safe to say that everyone's mental health has been impacted during the pandemic. This population in general may be experiencing it even more. They've moved, their situations have changed, they have freedoms taken away that they thought that they had while they're might be living in college or living away from their family members. And then something else is access to the internet or a smart device. You can't always assume that these folks would have consistent access to the internet, again, because they might be moving during the pandemic. And then the same thing goes with access to cell phones, which will make it difficult to recruit and have people participate in the study, especially if it's all virtual at this time. Then in terms of pathogenic vulnerabilities, as we've talked about, this population, especially if it's a subgroup of non-white participants, they might be turned off by research based on historical examples of research with this population. Next slide. Okay. So something to consider when you're thinking about how can we implement and design the study to mitigate the vulnerabilities is snowball recruiting. So if we're able to recruit a few different participants through traditional methods of social media or tabling at events, then you could consider asking those initial participants to recruit friends or family. This reduces the risk of potentially outing someone. The people that they would recruit, let them know they should only be recruiting people that they think would be comfortable participating. It would be safe for them to participate. And then in terms of when you're doing your participant screening, it's a good idea to ask participants ahead of time, do you have a safe space to take the survey? Do you have regular access to the internet and a device? Is there somewhere at home or wherever you're living currently that you can be on your own and participate in this study in privacy? And then same goes for mailing STI HIV kits during your screening. You want to ask them, is it safe for us to mail this test kit to you? Is there a specific label that we should use when sending it home to you? And then this is always a good idea. I'd say even now during the pandemic, it's a very, very good idea is to proactively offer mental health, COVID-19 support, other hotlines and resources that you think this population might benefit from receiving. You can build that into your recruitment script. When you're talking to them about this study, you can build it into your online survey materials. You could send a letter home, email a letter, whatever you think the best way is to reach the population. Okay, so as an IRB administrator, this is a slide that I have the most to talk about here. So when the study comes across IRB's desk, how might we, the IRB, review and think about the proposed study design? So at least at APT, when someone is proposing recruiting only via social media or via dating apps, it does sort of send out an alarm bell. Is this the safest way to reach people, especially this vulnerable population? So consider if there are other creative ways to reach this group, like we mentioned, the snowball recruiting. And this will be especially difficult during COVID to reach them in person, but perhaps there is some social setting that could be still appropriate. The risk-benefit ratio, that's something IRBs are continually talking about. So it's okay to exclude specific groups if it looks like the intervention is going to provide more risk than benefit. For example, if we said a student is living at home during this semester due to COVID-19, their parents do not know about their sexual preference, you don't want to put them at risk of harm by participating in the study. And then the regulations do allow for a waiver of parental permission. This group, youth, they do have other vulnerabilities, so that's why parental permission in general is the best practice. But given the situation, it could be important for the IRB to weigh the pros and cons of potentially waiving that parental permission. It is allowable under the regs, so you just have to discuss it carefully as an IRB. And then, as I said, IRBs might have some questions about using dating apps or social media. And in general, that's because the terms of service for the apps are all unique. And we have seen the case sometimes where once data is shared on an app, it then becomes owned by the app itself. So we don't know what could happen with that data once the app owns it, who they're sharing it with, how they're using it, how they're analyzing it. So that's something to really consider in your consent is, are you explaining very carefully that by using this app and interacting with a study recruiter on the app, your data might be vulnerable to being shared outside of the app? And again, because they're youth, either, maybe they really understand this, or maybe they don't because they haven't had a lot of experience with it. Also, terms of service, apps might not allow for study recruitment at all. So you want to make sure that, you're not using any coercive methods to recruit participants if you're posing as a potential match, perhaps on the app, but in fact, you're trying to recruit them into a study. All right, so now I'll take questions if there are any, or ideas, thoughts, additions to what we've discussed.
Attendees can feel free to submit questions in the chat, or feel free to unmute yourself and ask a question verbally if you'd like.
Thank you, Shana. Okay, well, maybe you're saving questions to the end, which is completely fine. So we've got about 13 minutes left, and we've got one more case study. And then hopefully we'll have some time for questions. Any come up? Okay, so I'm starting my timer again for our next case study. 2 minutes is a really long time to sit in silence. When we did the dry runs, we didn't actually practice with a real 2 minutes, but lesson learned. All right. Sure, you're all reading while I'm still talking, as you should be. Okay, next slide, please. So, as I'm sure you understand, this is a different population with different vulnerabilities, but the core tenets of protecting the study population when participating in a research study are still the same. So in terms of inherent vulnerabilities, veterans are very likely used to acting in a functioning system of hierarchy. Depending on their experience, this is something that they may be comfortable or uncomfortable with. So when recruiting and thinking about the study, consider who's the first person, and then also all the subsequent people that are going to be talking to the veterans about the study. If someone is dressed in a white coat compared to plain clothes, they might have a different reaction from the veteran. And then similar to the LGBTQ population from case study 1, this population may have a higher baseline stress, as Laura talked about with us, with her patients. And this could be exacerbated by being in a hospital setting. And again, especially if they are coming to the hospital thinking that they might have COVID. Now, in terms of the situational vulnerabilities, you want to make sure that the materials have the proper pronouns. So there are vulnerabilities related with gender identity that can be reflected in a positive way in all of your study materials. For example, the list of response categories for gender should be inclusive. You want to make sure that each person is asked all the questions about gender. And then in terms of the person asking the questions, are they wearing their pronouns on their name tag? And then again, like the previous case study, there could be a historic relationship with research, but also a historic relationship with medical institutions. So depending on the transgender person's lived experience, they may have negative perceived notions of working with and being in a medical institution. The institution-specific policies around gender are very likely going to vary. So because it's a multi-site study, there are very likely going to be multiple IRBs or research ethics offices involved. You want to make sure that all site documentations have that inclusive language and are using a trauma-informed or specific population-informed lens. It can be difficult for the IRB of record to enforce the importance of sticking to the originally approved language that is inclusive, but hopefully it's the case that all hospitals will understand the importance of the inclusive language. And that also goes with having staff wear the name tags with their pronouns. So because the policies are going to vary, there are a few things that you might need to be more proactive about reinforcing across the different sites. Okay, so this is an important question. The example that I'm going to use is important right now. So everyone's in a time crunch at a hospital, I would assume. I have never worked in one, but based on experience as a patient in a hospital, they're a busy place. There's a lot happening. There are a lot of patients to see and treat, again, especially during COVID. And now that we are in the after Thanksgiving spike and about to enter the next holiday spike. So if the person conducting the screening is rushed, we want to make sure that they are taking their time to ask all the questions of the study population. They should not assume someone's pregnancy status based on how the person sitting in front of them looks. So if the participant is asked their gender and they choose male or transgender, the next question should still involve a question on pregnancy or nursing. And as you may know, this is really important right now as the vaccine is getting rolled out. They have not been, any of the vaccines that are seeking FDA approval have not been tested on pregnant women that I know of. So it would be a miss to set this patient up to receive the vaccine. So this all reiterates the importance of having a private space for study interactions and taking your time going through the questions. Next slide. Okay, so here at APT, these are some of the questions that we are requiring teams to answer if they are proposing in-person data collection. So as we've been discussing, we don't want to forget to apply the correct trauma-informed or gender-informed lens to how we review the materials, but then we also need to add on that COVID layer to our research studies and IRB review. So one question that comes to mind is there really a requirement to do any data collection or recruitment in the hospital? Is it possible that someone with a COVID-19 diagnosis could be recruited as they are leaving the hospital, and all study activities could be done virtually from the comfort and safety of their own home? If the study team says, yes, it is really important to have in-person data collection while they're in the hospital, or recruitment at least while they're in the hospital, you need to make sure that study participants are not having unnecessary surveying or questions done while they are in the hospital. They're likely very uncomfortable, so it could be inappropriate to be surveying them, and just consider, could these questions wait until after they're out of the hospital? Something to also think about is PPE. You know, we do not want the study, the researchers, to be taking away the PPE supplies from those who are actually treating the patients. So make sure that that risk is mitigated and considered. And then how to protect the staff. So if we do decide to go forward with research during someone's hospital stay, you want to make sure that they are sitting 6 feet apart, they're having limited exposure, they're having a short amount of time in contact with the patients and in the hospital. And then you want to train the data collectors on reducing risks, all the ones that we've just talked about, but in general, reducing risk through a study by becoming, or by being a data collector. And then you need to think about, if a researcher does test positive, what is that action plan? You know, it probably seems obvious that they would stop, they wouldn't conduct the research anymore, they would stop coming to the hospital, but you do need to have a documented plan for if that happens. Okay, so that is the end of our formal presentation. If anyone has questions, as Shana said, please feel free to enter them into the chat or unmute yourself, and we'd be happy to discuss. We've got about 3 minutes left.
Okay, we'll wait another minute in case someone's in the middle of typing something in the chat. Again, if anyone has any questions or comments, you can unmute yourself or submit it into the chat.
I see one question in the chat from Miles Gideon. That IRBs/HRP use the inherent, it moved when another one came up. Would you study, or how else would you apply that framework? Laura, I think this is a good question for you, and or
I'm unable to see the chat. Shana, do you mind reading it? Jonathan, your internet is a little spotty.
Sure. So this question is from Miles. Would you recommend that IRBs/HRPPs use the inherent situational pathogenic framework when reviewing every study, or how else would you apply that framework?
I can take this one. So I can say that I've been working in the IRB Adapt for 7 or 8 years now, and I hadn't thought about that specifically, but going forward, I certainly will. It's a way to really break down what you should be thinking about with your risk benefit analysis, and you know, especially for a vulnerable populations, I would recommend that. Yes.
And I would piggyback off of that. When I think of direct patient care, I'm not always thinking specifically this is a vulnerable person, but rather now I'm kind of looking at just trauma-informed care as my standard, and assuming, you know, things so that I can provide just sensitive care generally. I think that it's a good framework. It's a good place to at least have sort of an inclusive lens, depending on, you know, whatever the population.
Sorry, my internet has been spotty. There's another question in the chat from Chris, and I know we have limited time, but I did want to acknowledge it and like try to answer it. She asked, how do we take care of participants all the way through, even the publication stage, so that they are represented the way they want? And one of the things that I have experienced conducting research, doing research projects, and going through the publication phase is that dissemination has been a big issue in making sure that the work that a lot of these participants are volunteering for, giving their energy, time, and like oftentimes their body to research aren't included in that next step of the dissemination phase. So making sure that at the forefront, they are being included in that by participating in community advisory boards, making sure that that information is being doled out to them as obviously as available throughout the research stage, not just all the way at the end, not just via like, here's a publication for you that is being sent to them that oftentimes might not even be super accessible for those folks who may have participated, but just having ways in which that like they can have touch points throughout the study. So like from beginning to end, making sure that there's some type of community involved and making sure that the participants have a space that they can voice any type of concerns that come up throughout that process. And then even beyond just publications, thinking about more creative ways in which you can do that type of dissemination for the research that you're participating in. Are community lecture, community events where there's just like a discussion where they can, what my experience was in this study. So having space for them to actually talk about what it was like being in the study so that they have that active voice, not just assuming and like hoping that they understand what went on while they were in the study.
Great, thank you. So we are at time, so I want to thank Katie, Laura, and Jonathan for a great session today. Conference evaluations will be sent at the end of each week. Upon completion of the evaluation, you'll be able to access your certificate of attendance. Session recordings will be available within 5 days of this airing. Thank you all again. You may now disconnect.